Hi everyone, can you hear me? Hi everyone, am I audible? So, how's your INI-CET preparations going on? I think we can have a discussive interactive section so that it won't be boring for you. So, for preparing for this institution exams like INI-CET, the most important step is to see the previous year questions. I know almost all the faculties must have repeated this thing because we know previous year questions will be repeatedly asked. Not the questions they won't repeat. What they will repeat is the topic. So the topic will be repeated again and again. So you should be familiar with the topics. That is the most important part. So today, I think I have covered in this presentation. I have covered almost all the important questions from last 5 or 6 sessions of INI-CET. So regarding radiology, I think we will be having a healthy discussion. So if you are having any doubt, please let me know. We will clear and go and move forward. Okay. So, so this is the first question. So this was a question which was asked in INI-CET 2022. So they asked, so this is a radio anatomy questions. Okay, so this is a question that collaborates both radiology and as well as anatomy. So they asked to identify the marked segment of liver. So as we all know, there are 8 corneal segments over the liver. So there are 8 corneal segments we know. So they asked to find out which segment was this. So this was the question. So first of all, we should know the anatomy. So we know the liver has been divided into 8 corneal segments and 2 lobes. So there is a right lobe and left lobe. So this part is the right lobe of the liver, and this part is the left lobe of liver. And we know that this caudate lobe is a separate lobe, which is not comprised either in the right lobe or left lobe. So in the left lobe, there is 2, 3, 4A, 4B. There are 4 segments in left lobe and 4 segments in right lobe. Okay, so this is how it is divided. So we can simply divide it as the superior segments as well as inferior segments. So this is the portal vein, and portal vein divides into right branch of portal vein and left branch of portal vein. So the segments above this division of the portal vein can be termed as superior segments, and the segments which are inferior to that can be termed as the inferior segments. So if you see 2, 4A, 8, and 7 will be the superior segments, and F, that is 3, 4B, 5, and 6 will be the inferior segments. So you know the anatomy well. So you know the main purpose of this is for the surgical resection, and the division is made out by what? The division is made out by the branches of hepatic veins. Okay, so this is the right branch of hepatic vein, I will change the color. So this is the left branch, this is the middle branch of hepatic vein, and this is the falciform ligament and left branch of hepatic vein. So it is this hepatic veins. See, this is the right branch, this is the middle branch, and this is the left branch. So this is the hepatic veins which divides this right lobe into segments 5, 6, 7, 8, and left lobe into segments 2, 3, 4, and 4A, 1, 4B. Okay, so this is how. So if you go back and see, here in that image, this is the IVC, this is the portal vein. So, and this was the right branch of hepatic vein was seen here. Middle branch of hepatic vein will be seen here, and left lobe here. So the answer for this question was segment 5. So according to this, if you know the anatomy, you will be able to write the answer. But I will tell you one tip. In exams, we should know that one thing is, since there are two divisions, that is superior lobes as well as inferior lobes, we know here the liver will be situated here, and just above the liver we will be able to see the lung fields. Okay, so if you are able to see the lung fields, then usually it will be the upper lobar segments. That is, if you are in the image, if you are able to see the lung fields, then it will be the upper lobar segment. So if you see, so then it will be 7, 8, and 4A and 2. So this is how it. Okay, and if you are seeing kidneys nearby, we know the. So if you come down, the inferior segments will be near the kidney. So if in the image they are giving kidney, then you can easily understand that it is an inferior section. So it can be either 5, 6, 4B, or 3. I hope it is clear. So in exams, you should there is no need to waste much time. If you are able to see the kidney, then you will be easily naming that as inferior section. And if you are able to see the sections of lung, see jet black hair. So that means it is upper sections, so superior lobe. I hope it is clear. Okay. If you are having any doubt, please let me know. So this is how easily we can categorize the segments of liver radiologically. So this was another question which was asked in INI-CET 2022 November. So in this question, the examiner was telling a 45-year-old male who came with the complaints of abdominal pain, and the catch-hold point was non-contrast CT abdomen of the patient was taken. So the examiner is telling you non-contrast CT is taken, and what you are seeing is you are able to see what? You are able to see the one lesion which is bright, that is hyperdense in CT, a lesion which is hyperdense in CT. So you are able to see a hyperdense lesion in CT. So what all are the lesions that will be hyperdense in plain CT? So that is the catch-hold point here. So you should understand that bleed and calcification. So these are the two things that will be seen hyperdense in plain CT. See, here you are able to see a very bright object in. If you see, this is the lung field. So probably this is segment 7 and 8. So this is probably there is in segment 8 of right lobe of there is a well-defined calcified lesion. So this is how the question is asked. So we know among these lesions, it is hydrated cyst that is very much prone for calcification. So this question was answer for this question was hydrated. And if you go through the previous year questions, you will be able to see multiple questions regarding hydrated. So before going to the exams, you should read the pathology, microbiology part, pharmacological part, management part, radiological part of hydrated. Then only you will be able to score best in the exam, because in INI-CET patterns they will repeat the session, they repeat the important topics again and again. So in last year options, they give the options of hemangioma, FNH, hydatitis, hepatocellular carcinoma, etc. So you should know how to differentiate all these things. You already know. You already know how the hemangioma, how HCC, how FNH will be seen in imaging. So the thing is, all for this three diagnosis, what we should do, we should get a contrast enhanced CT, not a plain CT. That is the first point. Okay, we cannot tell a hemangioma or HCC or FNH with the help of a plain CT. We should need a triple phase CT, that is a contrast CT in 3 phases. Which are the 3 important phases? Arterial phase, venous, portal venous phase, and delayed phase. So 3 phases are required for making the diagnosis of hemangioma, HCC, FNH, or any other liver lesions rather than these calcified lesions. Okay. So first of all, we will see what happens in hemangioma. We know in arterial phase what happens is there will be peripheral discontinuous nodular enhancement in arterial phase. What happens in venous and delayed phase is there will be progressive enhancement. So I have already discussed this in my previous classes. What happens is this hemangioma is made up of what? Fibrous tissue. So these fibrous cells are very lazy cells. They are very lazy. So they won't take up the contrast in the first phase. Arterial phase is the first phase. But first, what happens is first the contrast will go through the arteries, then it will go through the veins, and then it is excreted by the kidney. So that is why we will get arterial phase, venous phase, and delayed phase. So this hemangioma, the central portion of the hemangioma is predominantly made up of the reticuloendothelial cells or the fibrous tissues. Okay, so all these cells are very lazy cells, so the contrast uptake will be very slow. So the central portion of the contrast, the lesion will be getting filled with the contrast only in the delayed phase. So the first phase will be having peripheral nodular enhancement. Okay, peripheral nodular enhancement. So this is a typical pattern of hemangioma. All this we have already discussed. What happens in HCC? You know, 80% of the normal liver is supplied by the portal venous system. Only 20% is supplied by the hepatic artery. And the most characteristic feature of hepatocellular carcinoma is it is supplied by the hepatic artery. So since it is supplied by the hepatic artery, the lesions will be intensely enhancing in the arterial phase, and they show rapid washout. They show rapid washout. So if you are getting arterial phase hyper enhancement and rapid washout as the clue points in your question, then the answer should be hepatocellular carcinoma. The physiology behind this is very simple because hepatocellular carcinoma is supplied by hepatic artery. So the contrast will reach the lesion through the arterial phase. Immediately after the phase is over, because of high vascularity of the tumor, it will immediately wash out. Okay. And FNH, we all know, this is also very much important because multiple times asked, it will be having a central stellate scar. Okay, it will be having a central stellate scar. The scar will take up what? Sulfur colloid, technetium 99M sulfur colloid. It will be bright in T2. All these points we have discussed multiple times. Okay, so before going to INI-CET, you should understand and read about the liver lesions because last time they asked about hydatiditis, which is appearing calcified in a plain CT. So this time they may ask about hemangioma, HCC, or FNH. You should know how to differentiate between FNH and fibrolamellar variant of hepatocellular carcinoma. All these things we have discussed. All these things are in your note. Please go and read and go before your exams. Okay, I hope that is clear. So moving forward. Sorry. So moving forward to the next question. This was also a question that was asked in INI-CET 2022. So in this question, this was the same question regarding hydatiditis. That is why I told you hydatiditis is very important because in this question, they gave an image of renal hydatiditis. This is an MRI image. This is the kidney. And you are seeing, see, a multiloculated lesion filled with fluid. Why I am telling this as fluid is because this is a T2 weighted image with bright fluid seen as bright structure. Okay, so this is a multiloculated hydatiditis. They were asking you to find out the wrong statement regarding this condition. Okay, they were asking you to find out the wrong statement. The first sentence was cyst contains, if the cyst content leaks out, it will cause hypersensitivity. You know that is correct. Albendazole should be given before nephrectomy. That is correct. It is caused by dog tapeworm. You all know the pathology, you all know the microbiology part, because man is a accidental host. You should know the cycle before you go to the exam, and you should know the part, and you always should understand that FNAC should not be done, because it will cause us healing, it can cause us, because in FNAC what you are doing, you are inserting a needle into the lesion and taking out the sample. So there is a risk of spillage. The patient may go for hypersensitivity immediately, that can cause severe risk of life. So don't go for FNAC though. So that was the wrong statement in this. So what I'm telling is, read hydrated cyst, all the pathology, pharmacology, microbiology, surgery, and medicine part. Read about pair, all the treatment part, and all the other tests. Okay. So before you go to the exams. So this is another question which was asked in INI-CET May 2022. So this was a case, this is a classical case, a 34-year who was brought to the casualty after road traffic accident. The patient had poor GCS. So what sometimes the examiner will tell the GCS is 3 or 4 out of 15. So what they will do is they will definitely go for a CT brain. But in this patient, in spite of the poor GCS, the what was the GCS CT brain was normal. So this is the clue. CT brain may be normal. The CT brain was normal, but the GCS was poor. So you all know the diagnosis. What is the diagnosis? The diagnosis is pretty straight and clear. The diagnosis is DAI, that is diffuse axonal injury. Okay, so diffuse axonal injury. So the diagnosis is very clear. So because of some shearing forces to the brain parenchyma, there will be multiple punctate microhemorrhages in the brain. So that is the pathophysiology of diffuse axonal injury. There will be multiple punctate microbleeds, and these microbleeds are commonly seen in gray-white matter interface. So these are the potential questions. Where will these microbleeds be seen? They can be seen in the gray-white matter junction, corpus callosum, splenium of corpus callosum, or in midbrain structures. Okay. So if you want to find out these microbleeds, what you should do is you have to go for MRI brain. Okay, you should go for MRI brain. Last year, when last INI-CET May, what they did was they gave the image of the brain with microbleeds. See, there are multiple tiny dots like this. All these dots are called as bloomings. Okay, all these dots are called as blooming. So which sequence help you to find out blooming? So this was the question, and we have discussed this before. So we should know the answer for this is SWI. Okay, this is known as susceptibility weighted imaging. Okay, this is known as susceptibility weighted imaging. So SWI is the sequence that help you to find out microbleeds. Okay, so this is the concept. During your internship or during your practice, you might have seen that CT usually will be having 1 or 2 films having the bone window and brain window, but MRI will be having multiple films, okay, or multiple sequences. So it will be having diffusion, T1, T2, SWA, GRE. There will be multiple sequences. So you should be just familiar with some of these sequences. You should be able to identify some of these basic sequences. Okay. So diffuse axonal injury, CT may be normal. Sometimes CT will also show punctate these pectical microhemorrhages, punctate small microhemorrhages in gray white matter junction or corpus callosum or midbrain, that brain system structures. Okay. So can anyone tell me what is this sequence? This is another sequence which was asked in NEET-PG, I guess. NEET-PG exam. Can anyone tell me which is this sequence? This is a very, very important sequence. This is a sequence that is of prime importance when you are dealing with a stroke. Okay, this is the sequence of prime importance when you are dealing with a stroke. You are seeing something very bright like this. So this sequence is known as diffusion weighted images, or we will call it as DWA. Okay, so this is the sequence that pick up stroke or infarct at earliest. So that is why this sequence is important. That is why they are asking SWA in exams, DWA in exams, because DWA will pick up infarct at the first. Okay, so neurologists will be very keen. They will be calling us and asking is DWA positive or not, because DWA positive means there is something in the brain causing diffusion restriction. Stroke is, that is infarct is one of the major causes for diffusion restriction. Other is this image, this table, which we have already covered in our previous section before NEET-PG. So this is very, very important. You should know how to differentiate between T1 weighted images, T2 weighted images, and flare images. I hope you know this. So the most important thing is, first you have to see the CSF. If CSF is bright like this, then it is T2. There is no doubt. If CSF is bright or hyper intense, then it is T2. Then the game is over. Okay. Always the difference, always the doubt will be between T1 weighted images and flare images. Always understand when a 1-year-old child will be very nice and very innocent, okay, he will be very true. So his what happens is he's just like that, a baby, just like a small baby. T1 is also very true sequence. Okay, it will be having gray matter as gray in color, white matter as white in color. See, this is the white matter. It is in white, and gray matter is seen as gray. So T1 is a nascent sequence, very pure sequence. It is very best for anatomy, you all know that. So in T1 weighted images, the gray matter will be gray in color, white matter will be white in color. Fluid will be black in both T1 weighted images as well as flare images. Okay, but in flare images, this gray matter will be seen bright. See, the gray matter is bright and inner white matter is gray. So there will be differentiation. That is how you should differentiate T1 and flare in exams. It can be confusing at times. So relax, take a second, see the gray matter and white matter. Always remember, brain is like a coconut, cut open coconut. Central portion will be water, that is water. Then inside is the gray matter, outer side is the white matter. So, sorry, inside is the white matter, outer side is the gray matter. See, this is the white matter and outer side is the gray matter. So this is how you should differentiate the sequences. All these are repeat questions for INI-CET AIMS exams. Definitely, they may ask to identify the sequence or something more from this. Okay, so you should be very careful before you go. Other very important part is CNS infections. If you attempted NEET-PG this year, you might know that multiple questions were asked from the CNS infections, one pediatric CNS infection as well as adult CNS infection. So it is very potential area for NEET-PG also. Here also this, see, the patient is brought to unconscious to the ER with a severe neck rigidity. So with this history, they made the provisional diagnosis of meningoencephalitis. So everything is given in the question, but the examiner is asking you to make the diagnosis with the help of MRI, and they are given a contrast image like this. What you are able to see is this is the midbrain. So you are able to see cisterns around the brainstem, that is basal cisterns. So if they are giving you the image of basal cistern like this, and you are seeing some bright structure around this basal cistern, that means there are some exudates around the basal cistern. Okay, so if you are able to see some exudates around the basal cistern, there is only one answer, that is tuberculosis. So this is one of the very much important point that you should know about tuberculosis. Definitely one question from tuberculosis can come. It can come either from pathology, microbiology, pharmacology, medicine part, or radiological part. But understand, if they are asking about CNS infection, about CNS tuberculosis, then always remember basal exudates. So that is the one important point. Okay, sometimes it will be seen as tuberculoma also in brain, one single lesion with ring enhancement, tuberculoma. But usually questions are asked regarding this meningoencephalitis and basal exudates. So you should be very careful. So other options were cryptococcosis, toxoplasmosis, neurocysticercosis. You should be very careful. We should be very thorough with all these things because they have been asked any number of times. Last time in NEET-PG, they were repeatedly asking about HIV infection. So they can ask about toxoplasma related with HIV and all. You know, toxoplasmosis, this cryptococcosis, all will occur in immunocompromised individuals. Okay, when the CD4 count is less than 200, these infections are very much prone. Okay, so what happens in toxoplasmosis is, in adults is, they will be having predilection to the basal ganglia. See, there are multiple lesions in the region of basal ganglia, and if you give contrast, you will get a classical sign, that is eccentric target sign. Eccentric target sign. Okay, so we will get a classical sign known as eccentric target sign. It is not in the center, it is not concentric here. So after contrast administration, you are getting a eccentric target like this. So that is known as eccentric target sign, which is seen in toxoplasmosis. So that is one key part here. Then cryptococcosis is very easy. It is also seen in immunocompromised patient, usually in the basal ganglia. See, what happens is this basal ganglia will be filled with multiple cysts. What happened? It is not cyst, it is pseudocyst because of the gelatin capsules of the cryptococcus. You know, the cryptococcus is having this gelatin capsule. You will use some Indian ink or some dye for that. You all know those microbiological part. But for radiology, you will be seeing soap bubble appearance. Very easy. Okay, there will be multiple soap bubbles in radiology, but cryptococcus will be having soap bubble appearance in brain parenchyma. Okay, I think it is very easy. This is another question from NEET 2023. Okay, HFE encephalitis. What is the characteristic feature of HFE encephalitis? Is they will affect the bilateral temporal lobes. See, there is bright signal in bilateral medial temporal lobe. This is the area of hippocampus, amygdala. That is area of memory. Okay, so bilateral temporal lobe involvement. Sometimes hemorrhage will be seen. All these are the features of HFE encephalitis. So for a quick revision, tuberculosis will usually affect the basal systems. There will be basal exudates resulting in enhancement in tuberculosis. Toxoplasmosis usually seen in immunocompromised, usually affecting the basal ganglia region. Eccentric agricine, all these are the points favoring toxoplasmosis. Cryptococcosis, what happens is there will be multiple pseudosis, gelatin-filled pseudosis, giving a soap bubble appearance. So that is the classical feature of cryptococcus. So you should read about the pathology as well as microbiology part, also the treatment, because sometimes they will be asking you about the treatment of cerebral cryptococcosis also, amphotericin, and what combination you should give. All these will be the questions. And HSV encephalitis. Okay, herpes simplex virus encephalitis, which is very having predilection to the temporal lobes, usually bilateral asymmetrical involvement. Okay, so that is how it will come in. This is another important question which was asked in 2022 May. So here this was a patient, 70-year-old male with a painful limb. Patient don't have any history of drug intake, no history of trauma. You have to make the diagnosis with the help of radiographs. See, this is the right side of the patient. This is the left side of the patient. Here, left side actually look okay. You are able to see the sphericity of the femoral head. But in right side, you are able to see the collapse and loss of joint space, arthritic features, etc. So you should make the diagnosis with exclusion. Sorry, what happens is first we can see AVN. Yes, it is a potential cause. Tuberculosis, hip, a potential cause. Ankylosing spondylitis, another potential cause. But you can rule out ankylosing spondylitis because first of all, in ankylosing spondylitis, what happens is it will involve the SI joints. Here, the SI joints are normal. So we can rule out ankylosing spondylitis. Rheumatoid arthritis is very rare in large joints. Usually it will be affecting small joints. It can affect large joints, but it is very much common in smaller joints, like in hands or feet or wrists, etc. Okay, so that is the thing. And what happens in TB is TB and rheumatoid arthritis usually will be having similar picture because there will be inflammation. So because of this inflammation and hyperemia, there will be osteoporosis, periarticular osteoporosis, periarticular erosions, uniform loss of joint space, etc. So both these features will be common for TB as well as inflammatory arthritis. Nothing is seen in this. And here what you are seeing is some collapse as well as there is collapse as well as arthritic changes. So this was a case of avascular necrosis. AVN can occur idiopathic. That is the most common cause. It can be associated with the smoking, alcoholism, corticosteroid induced, many other drug intake. Okay. Also, it can be seen post-traumatic, but idiopathic is the most common cause. So this was a case of idiopathic AVN, and you should all know the classification of AVN. What is the classification known as? The classification is known as Fickett and Orlet. You should go back and read your orthopedics notes. They will be telling you about Fickett and Orlet. There are 4 stages: stage 1, 2, 3, and 4. In stage 1, usually MRI will X-ray, MRI. Stage 1 will be normal in X-ray. MRI will be showing edema in stir sequence. Stage 2, there will be geographic area of destruction. Stage 3, there will be collapse. And stage 4, there will be arthritis. So go back and read the Fickett-Orlet classification because it is very important in avascular necrosis of hip. There are 4 stages. Okay. So this is another repeat question from NEET-PG 2022. Sorry, INI-CET 2022. A patient with the peptic ulcer having air under the diaphragm. Why I have put this question is perforation is very important. Okay, perforations, the questions without there won't be a paper without perforation. Okay, because it is the most common surgical emergency. You all know that. You should know the management of perforation, how to diagnose perforation, what will you do if the X-ray is doubtful. All these things you should know. So here the examiner was asking what you do further. Here you are able to see the air under the diaphragm. So there is no need for CCT because you are confident about the diagnosis. You should start IV fluids and you should operate the patient. Okay, you should do exploratory laparotomy. There is no need for UGI scopy. So the answer was 2 and 3. You all know this. So why I put this is Pneumoperitoneum is very, very important because there are multiple signs in pneumoperitoneum, multiple investigations in pneumoperitoneum. Pneumoperitoneum is very important. So this is a CT image showing pneumoperitoneum. See, you are able to see the jet black air. If you see the Hounsfield unit, it will be around -1000. Okay, it will be around -1000 here. So this is how pneumoperitoneum will be seen in CT. CT is the most sensitive investigation for pneumoperitoneum. For any investigations with air as a pathology, CT is the most sensitive investigation. Okay, because CT will pick out at least 1 ml of air. That is the beauty of CT. Okay, even 1 ml of air, CT will pick up. Okay. If you are going to take CT, always better to do CECT abdomen with IV and oral contrast, because if there is a perforation in the stomach like this, what happens is there will be contrast pooling extravasation in the region. So we will be able to find out the area of perforation also. If you are doing CT, always better to do CECT with oral and IV contrast, because that will help to localize the site. Always remember, always give iodinated contrast because it is water soluble. Okay. Don't give barium when you are suspecting perforation because it will result in multiple complications. Don't give barium. Okay, always give iohexol. Okay, in exams, they can ask you, they can confuse you. So whenever you are suspecting gastrointestinal tract perforation, never ever give barium. Always give water soluble iodinated contrast because barium is water insoluble. It will go from barium granulomas. It will cause us multiple comorbidities, multiple problems. So never give barium. That is the take home point. Okay, always give iodinated contrast because it is water soluble. If they are asking which is the best X-ray view, always remember CSR erect. Okay, chest X-ray erect view is the best view. And if the patient is not able to stand, you can go for left lateral decubitus view. All these points has been asked multiple number of times in various entrance exams. Okay, so this has been asked multiple number of times. So you should be thorough with all this. You should thorough with the different signs of pneumoperitoneum like regular sign, football sign, falciform ligament sign, dolphin sign, cupola sign, telltale triangle sign. I have discussed almost all the signs in my previous classes. So go back, see all the signs of pneumoperitoneum because they can ask you in match the following format. Because last year also there was one match the following questions regarding signs. So these AIMS exams are a little bit tricky. You should work smarter, not harder, because you should know which pattern of questions are they are asking. You should be ready for those patterns. Okay. This is another important question. A 50-year-old man with high blood pressure. His blood pressure was around 100, 160, 100. His heartbeats was 120 beats per minute. He was brought to the emergency room. So you ordered a CCT. You are getting a CCT image like this. So how this condition is being managed at ER? So what is the first step of management? Okay, that is the question. So what is the diagnosis here? This is a classical image which has been asked multiple number of times. Even from the clinical scenario, you should make the diagnosis. With the help of the image, then the diagnosis should be evident. See, this is the ascending, this is anterior aspect, this is the vertebra, so this is the posterior aspect. So this is the ascending aorta, and this is the descending thoracic aorta. So you are able to see a flap here. So you are able to see a flap here. So there is a flap in the ascending aorta. So this is ascending aortic dissection. Okay, this is ascending aortic dissection. So they are asking you how will you manage dissection? Will you do a emergency surgery in the ER at first? No, you can't do a surgical repair. You don't need to activate any heparin or not. First you have to do is you have to control the heart rate because the heart rate is around 120 beats per minute. So you have to give beta blockers here. Okay, beta blockers you have to give. So this is how you should think. Okay, so this is the aortic aneurysm. Aortic aneurysm with a dissection. Dissection is a very common spotter. So this is the flap, and this is the false lumen, and this is the true lumen. Okay, when there is a flap causing the dissection, there will be blood going in. So it will cause the formation of one false lumen and one true lumen. Okay, so always remember true lumen will be small in most of the thing. False lumen will be large. I don't think they will ask like that, but just remember. Okay. So anatomy is very, very important. Anatomy they have asked multiple number of times. So always understand this is the anterior part, this is the posterior part near the vertebral body. So coming to the anatomy of cardiac chambers, the anterior most chamber will be always what? This is the right ventricle. So if you know this is the right ventricle, then everything is easy. Then this is the left ventricle because this is always the right side and this is always the right side, left side radiologically. And you should always remember the posterior most segment will be always left atrium. So this is left atrium. So right ventricle is always the anterior most, and left atrium is always the posterior most. Okay, so this is how you should remember. So this is the anatomy. So this is automatically the right atrium. So this is right atrium, right ventricle, left atrium, and left ventricle. Okay. Now coming to the this is what is this investigation? This is CT pulmonary angiogram. This is CTPS. It is the CT pulmonary angiogram, which is the investigation of choice for pulmonary thromboembolism. Just to understand the anatomy, this is ascending aorta. This is descending aorta. This is main pulmonary artery. This is right pulmonary artery, and this is the left pulmonary artery. And sometimes you may be able to see a thrombus here. If you are seeing a thrombus between right and left pulmonary artery, that is known as the saddle emboli. Another spot. Okay, so all these are the things you should remember because pulmonary thromboembolism is a multiple time asked question. Sometimes they will give you the X-ray, they will ask you the signs like Western mark sign or Fleshner sign, the Chagas sign or Paul sign. Sometimes they will be ask you about VBQ scan, which agent is used for inhalation, which agent is used for perfusion. So all these are potential questions. Just before exam, read all the emergency questions. Pulmonary thromboembolism is a very, very important emergency condition. So you should be thorough with the investigation part as well as the treatment part. Okay. So moving forward, another multiple time asked question. Young fellow after RTA presenting to you with low BP. The BP is early 80/60. Respiratory rate is around 40 beats per minute. Pulse rate is very high, 120 beats per minute. So they have taken a chest X-ray, erect view, AP erect view. What is the diagnosis? What is the management? So here you can see this is the right side. They have given right. This is the left side. So if you see the left lung feels, it is normal. You are able to see the vascular markings. So it is normally inflated. You are able to see the vascular markings. But what you see here is this is hyperinflated. See, it is very much black. Hyperinflated. Or in radiology, it is very easy because you have to compare with the opposite side. If you compare the right side with the left side, this is much blacker, right? This is much blacker. So it is hyperinflated. It is because not hyperinflated. It is because the air is there. Okay, this it is because of the air in the pleural cavity, and you are not. There is no vascular markings. You are not able to see any vascular markings, and also you are seeing the sulcus. The costophrenic angle is deep. That is known as the deep sulcus sign. You are seeing deep sulcus sign. Okay, no vascular markings, deep sulcus sign. So the diagnosis is pneumothorax. Another repeat question, pneumothorax. What will you do for pneumothorax? You have to put a chest tube. There is no need for CT chest. There is no need for emergency thoracotomy. Emergency thoracotomy means you are opening up the chest. There is no need to open up the chest rib cage. There is no use of pericardiocentesis. What you have to do is you have to put a ICD. So where you should put the intercostal drainage tube? That is the question. You have to put it in adult. You have to put it in the triangle of safety. You should read about the triangle of safety, which is situated here. We should read the boundaries, borders of triangle of safety. You should know the size of the drainage tube. Everything is very, very important for INI-CET exams. Okay, another important thing is EFAST. Okay, this is an image of EFAST. EFAST stands for extended fast. Okay, in extended fast, we will also look for this pneumothorax. Okay, so here for same patient presented to the ER with the chest pain, EFAST image is provided. That what is the diagnosis? So this is the question. So ultrasound chest images are very, very, very important because this very routinely done nowadays. So you should be very thorough with this. So is this pneumothorax? Is this pleural effusion? Is this normal image or lung laceration? You should see this. You should identify the sign. You should see this. Consider these are multiple grains and these are water or tides, and we can term it as seashore sign, which is seen in a normal length. So you should be familiar with this image. You should be familiar with the seashore sign and stratosphere sign. Okay, all these are very, very important. Okay, because seashore sign is seen in a normal length. Because of the normal length and sliding, what we are able to see is because of the length, we are seeing multiple granularity like this. Okay, so that is why it is known as seashore, just like the sands, just like the sand in the shore of the sea. That is why it is known as seashore sign. And in a non-sliding length, when the length is not sliding, all the part of the length will be stationary like this. And you will be only seeing barcode or stratosphere. Okay, stratosphere sign or the barcode sign. And the most specific sign for pneumothorax in ultrasound is the presence of length point. Okay, because if you are seeing the differentiation between the stratosphere and the length seashore here, then that is known as the lung point, the marker between the collapsed lung and the pneumothorax, and it is the most specific sign is the presence of lung point. Okay, just remember that. So just remember, seashore sign is seen in a normal lung. You will be able to see multiple granules like this, but in barcode sign, only the barcode will be seen. No sand is seen. It is seen in pneumothorax. Very, very, very important. And you should understand the most specific investigation. I told you even 1 ml of air will be picked up by CT. So the most specific investigation will be always CT chest, and this is how air is seen in CT, causing the compression and collapse of right lung. Okay, and other important sign is the deep sulcus sign we have discussed. And you should understand that in case of tension pneumothorax, there will be hypotension because of the compression of the large vessels. You should immediately put a wide bore into the fifth intercostal space in adults and second intercostal space in children. And also the ICD is put in triangle of safety. And you should know the boundaries that is made up of latissimus dorsi, pectoralis major, and base of axilla at the level of nipple. All these are very, very important for your exams. Other thing is fast. Fast is very, very important because this is a multiple time asked question. A patient with a blunt trauma abdomen came to you. You did a fast in AIMS casualty. You are seeing this image. What is the diagnosis? Whether this patient is fast positive or negative. Okay. So this is the liver. This is the kidney. So this part is known as the hepatorenal pouch. This is the hepatorenal pouch. And you are seeing some echogenicity here. Okay. So this is the free fluid which is seen in hepatorenal pouch, which is also known as the Morrison's pouch. So Morrison's pouch is one of the most dependent parts. So when the patient is lying down and when you are doing the ultrasound, the fluid will be getting accumulated in the most dependent part, that is this Morrison's pouch between the liver and kidney. So you will be able to see this hemoperitoneum like this. And if you are seeing this, then you should understand that this patient is fast positive. There is free fluid. That is hemoperitoneum. You have to do. So if the patient is hemodynamically stable, you have to find the source of the bleed, whether it is from the liver or kidney or the peritoneum or mesentery or whatever it is. Then you should do CCT abdomen if the patient is stable. But if the patient is not stable, go save the patient by doing exploratory laparotomy. Okay, so the protocol is very simple. Okay, first you have to do the fast. You have to see whether the patient is fast positive or negative. If the patient is fast positive, if the patient is stable, if the BP is stable, then go for CCT abdomen. Find out the cause, whether it is a liver injury, splenic injury, or any other injury, renal injury, or whatever it is. Okay, but if the patient is very weak, if he is not hemodynamically stable, directly go and do a exploratory laparotomy. Okay, so that is the procedure. Very simple. Fast is very, very commonly asked. Don't make a mistake here. Fast is very, very important. Other important topic which is been asked multiple times is this: a 25-year-old female came to OPD. Also, this question was repeated again and again in this NEET 2023 also. I think they asked this is okay. Chronic low backache, some pigmentation is here and there, some test positive. What is the diagnosis? So here you can see they have given you the X-ray of SA joint as well as some SA joint as well as so the Sagittarius section, and also here. So this X-ray is very important. Why I am telling you is here you are able to see multiple intravertebral disc calcifications. Okay, intravertebral disc calcification. Also, the patient is having hyperpigmentation. So when the patient is having hyperpigmentation and there is intravertebral disc calcification, there can be only one diagnosis, that is alkaptonuria or ochronosis. So read about the biochemistry of alkaptonuria, read about the enzyme deficiency, how you manage this patient. Okay, but radiologically, what you will see is intervertebral disc calcification. So intervertebral disc calcification is the most common feature for alkaptonuria. Okay. Now coming to the other important condition is ankylosing spondylitis, which is more commonly seen in young adults. Okay. So the classical feature will be sacroiliacs, SA joint. Okay. The first involvement will be SA joint involvement. Then later what happens is everything will become ankylosed. Everything will become fibrous. Okay, that is the point. That is the problem. That is known as ankylosing spondylitis. So everything will become fibrous. Everything will become calcified. See, there is calcification of anterior longitudinal ligament, calcification of posterior longitudinal ligament, calcification of interspinous ligament, giving the classical dagger sign. If you are able to see calcifications here and here, then it is known as Crowley track sign. So ankylosing spondylitis is very, very important. Okay. So if they're asking you which is the first investigation to pick up ankylosing spondylitis, then the answer is MRI. MRI will pick up this edema of sacroiliac joint, and the sequence used is stir. If you're using a stir sequence, then you will be easily picking up sacroiliitis with the help of MRI. So the first investigation to pick up sacroiliitis or ankylosing spondylitis will be MRI with the help of stir sequences. Just remember the name of the sequences, it may help you in your exams. So another question which was asked in May 2019 AIMS is this. They give an image of this and they give multiple options. Just remember the thing, here you are able to see there is calcification of anterior longitudinal ligament, ossification of anterior longitudinal ligament. So this condition is known as DISH, also known as Forster's disease. So there will be idiopathic, DISH stands for idiopathic skeletal hyperostosis, diffuse idiopathic skeletal hyperostosis. There will be sparing of SA joint. Okay, there will be sparing of SA joint. That is how you differentiate between DISH and ankylosing spondylitis. Also, this is seen in old age. You know, ankylosing spondylitis is a disease of young 25 or 30-year-old man will be coming to you. He will be HLA-B27 positive, but DISH won't be having these features. It is seen in old age, usually involving cervical or dorsal spine. There will be involvement of anterior longitudinal ligament. And here another image of ochronosis with intravertebral disc calcification. So this is how you differentiate. All these images are very, very important. Go back and read. And for fluorosis, just remember, there will be interosseous membrane calcification. There will be interosseous membrane calcification. There will be calcification of sacrotuberous ligament. So all these are the ligaments that will get calcified in fluorosis. Okay, so you should know how to differentiate between ochronosis, fluorosis, ankylosing spondylitis, and DISH. Okay, so go back and revise before you go to the exam. This is another repeat question from last November. So which of the following part is obstructed? This is a classical image of coffee bean image of sigmoid volvulus. So this is sigmoid volvulus causing large bowel obstruction. So the thing you have to understand is you should remember how to differentiate between a sigmoid volvulus and cecal volvulus. Always remember sigmoid volvulus will be having this classical coffee bean appearance. You won't be able to see any hostra here. But see, in cecal volvulus, you are seeing multiple hostras. So in cecal volvulus, always some hostra will be seen. Sigmoid volvulus will be always directed towards the left. Cecal volvulus will be usually directed towards the right. So these are the two important easy points that will help you to diagnose in exams. Because exams, they will usually give you classical images. So in classical image, don't get confused. If you are seeing hostra, then it is cecal volvulus because sigmoid volvulus is always a hostral. And if you give barium enema, we will see bird peak appearance. Okay, bird peak appearance. Another bird peak appearance in barium swallow is seen in, achalasia cardia. So achalasia cardia is another condition with bird peak appearance. Okay, so all these are very, very important. Okay, then cardiac X-rays in pediatrics. That is another multiple time repeat question. Here the baby is presenting with the respiratory distress and cyanosis. Here cyanosis is the clue point to help you. So, and you are able to see a dilated right ventricle with a boot-shaped heart. So the diagnosis is tetralogy of Fallot. So you should see all the X-rays before you go. So tetralogy of Fallot is very important. What happens in tetralogy of Fallot is there will be pulmonary stenosis. So it will result in pulmonary oligemia. And most of the times the aortic arch will be right-sided and there will be overriding of the aorta. All these are the points you should revise. And other important spot X-rays. What is this? Here you are seeing narrow pedicle with enlarged heart giving a egg-on side appearance, which is seen in TGA. TGA is very much associated with gestational diabetes mellitus. Okay, so all these are questions you should remember. It is very much specific for gestational diabetic mellitus, very commonly associated with the GDM. So it will be giving an egg-on and egg-side appearance like this. Okay, this is tetralogy of Fallot, you know, boot-shaped heart, Corinth boot appearance. Another, this is a large box-shaped heart seen in Epstein's anomaly, which is seen usually in lithium toxicity. Okay, this is another classical snowman appearance seen in supracardiac type of TAPVC. All these are very much important. All these are very, very important. You should remember. You should see these images before you go to the exams. Okay, because it has been asked multiple number of times. So this was another question from INI-CET 2020 November session. When there is severe trauma involving multiple sections like brain, spine, or abdomen, you will do CT whole body, also known as polytrauma protocol. Also known as polytrauma protocol. So, which of the following is not included? So the answer is obvious. CT limbs we don't take. What we will do is we will do a CT brain with CT spine, non-contrast CT brain, non-contrast CT spine, plus contrast CT chest, and contrast enhanced CT abdomen. Okay, so these are the four parts we will take. We will take brain, spine, chest, and abdomen to rule out any major organ injuries, rib fracture, vertebral fractures, as well as cerebral hemorrhage. So this is the point you should remember. Won't be taking lips. Okay, so I hope that is clear. This is another easy question. Match the following. So that is why I told you always read all the signs, because you know rat tail sign is seen in carcinoma esophagus. You know that string sign is usually seen in pyrolic stenosis. Inverted umbrella sign is usually seen in tuberculosis, and football sign is seen in case of pneumoperitoneum. Okay, so all these are very important. Name of the signs are very important. Since they asked this in NEET 2020, sorry, in INI-CET 2022, they may ask some other signs, some other match the following examples. So always remember, always read the signs, named signs before you go for the exam. This is another interesting question from INI-CET 2022 November. So the patient had carcinoma prostate, high Gleason score. Bone scan showed increased uptake in bones with the reduced uptake in kidney and soft tissue. So there is a reduction, severe reduction in the uptake in soft tissue and kidney. So the result came as super scan. So the nuclear medicine physicists give the report of super scan, telling there is uptake only in the skeletal system, no uptake in kidney. So what is the reason behind this? Okay, so understand, in patient with the carcinoma prostate, there will be multiple osteoblastic metastasis, also known as sclerotic, okay, dense sclerotic metastasis. Because of this dense sclerotic metastasis, what happens is all the tracer material, all the technetium-99 MDP material will be gone and accumulated in the bones. So there is a reduction in the uptake in kidney. So you won't be able to see the kidney and other soft tissues. Everything will be in the bone, and we will term that scan as super scan. Okay, we will term that scan as super scan. Okay, so it is because of the increased osteoblastic activity of the mets. So that was the answer for that question. So always remember, osteoblastic mets are more common with prostate carcinoma. In female, it can be seen with breast carcinoma, and it will be seen as sclerotic areas like this. Okay, so next time they can give you an image of CT or X-ray. Okay, because sclerotic mets are seen in prostate cancer, whereas the osteolytic mets, these are the most common type of metastasis which is seen in all other type of cancer like renal or lung or thyroid or any other malignancies. Okay, so osteoblastic mets are characteristic of thyroid carcinoma. Okay, so that is the point. Renal lesions are very much favorite lesions for these INI-CET examiners. So that is why they are asking you this question. So last time also they gave an image like this and they asked you to find out. So this is the normal left kidney, but in this kidney there is some black lesion like this. So what you have to do is you have to see this intensity and compare with the intensity of the fat. See, both the intensities, this is subcutaneous fat. So if you compare this intensity with the intensity of subcutaneous fat, you can understand this is a fat containing lesion. So a fat containing lesion in kidney, always remember of angiomyolipoma. This question has been asked 2 or 3 times. Okay, that is why I have put this. I know it is little bit difficult, but just pay attention. Just compare the intensity of the lesion with the intensity of fat. Okay, that is how you will pick up, because if it is renal cell carcinoma, what happens is it will be having soft tissue. You know, all the cancers will be having soft tissue, so it will show contrast enhancement like this. It will show contrast enhancement like this. See, there is enhancement. See, there is enhancement. What happens is, this is a renal cyst, there won't be no enhancement at all. So in cyst, there will be no enhancement. It will be blank hypodense like this, and there is one classification known as Bosniak classification for cyst. Okay, so there is a classification known as Bosniak classification. Another important thing is this is oncocytoma. So I'm discussing all the 3 other options. All the 3 other options I'm discussing. Oncocytoma will be having this classical central stellate scar, star-shaped scar, central stellate scar. Okay. So this is a feature of renal oncocytoma. and it will be having central stellate scar. It is usually seen as associated with symptoms like Britt Dupe syndrome. So this oncocytoma can show some syndromic association. So renal lesions are very important. You should know how to see a cyst. Cyst will be very clear, no enhancement, just fluid-filled cavity, that is cyst. Oncocytoma with a central stellate scar, enhancing renal mass lesion, as well as angiomyolipoma. So this is another INI-CET May 2020 question. So this was a patient with HIV brain presented with headache, ulcers, and sodium. So you made the diagnosis of neurocystic cirrhosis. So what all features should be present? How to make the diagnosis using essential criteria of neurocystic cirrhosis? That was the question. So for making the diagnosis, what you have to do is you should get an MRI image with the Scolex. Okay, you should get an MRI image with the Scolex. See, if you see this, you can see multiple hypo that is black areas within the cyst. Okay, so that is the scolex of the parasite. That is the scolex of the parasite. Okay, so you should get an MRI image with the scolex and brain biopsy showing the parasite. Okay, so these are the two things. So actually speaking, there are three essential absolute criteria. One is histopathological demonstration of parasite from the biopsy of the brain or spinal cord, direct visualization of the scolex in MRI, and direct visualization of subretinal cysticercosis. So these are the three absolute criteria. Then there are major minor criteria like this. So last time they asked about absolute diagnostic criteria of neurocysticercosis. Okay, so you should read, you should understand. So if you want to make the diagnosis, then you should see an MRI image with the scolex, and also you should get a biopsy sample proven, or you should see subretinal cysticercosis. Okay, so these are the three essential criteria. Okay, absolute criteria. And always remember, there are 4 stages for neurocysticercosis. Just go and read. There are 4 stages: vesicular stage, colloidal vesicular stage, granular nodular stage, and nodular calcified stage. So they can give you images of any of this stage. See here in first stage, you will be able to see the scolex. Second, there will be much edema because of intense inflammation. Later, it will get calcified. So this is the condition of neuro-NCC staging, which is also known as Escobar staging. Just go and read the Escobar staging. Okay. Other important CNS childhood infection is to differentiate between toxoplasmosis and CMV. Very easy, I will tell you. In toxoplasmosis, what happens is there will be totally distributed T4T. Just understand T4. There will be total scattered calcifications here and there. Okay, there will be here and there calcifications. But what happens in CMV is there will be periventricular calcification, V4V. There will be periventricular calcification. In this NEET 2023, they give the image of this periventricular calcification. Okay. That is why this is very important. In CMV, always there will be periventricular calcification. In toxoplasmosis, there will be totally scattered calcifications. For T4T and V4V, just remember the mnemonic, just make the questions correct and get a good seat. Okay. This is another difficult question which was asked in last May exam. So here the patient was brought to emergency room after RTA, chest X-ray was taken. So in which of this case you will investigate further? Okay, in which of these cases you would investigate further before putting a tube? So we can see each images. See here there is an opaque left hemithorax. So this opaque left hemithorax will be having multiple differentiations, total consolidation, total collapse, like that. But there is no mediastinal shift, so it may be total consolidation. So you have to do a CT and confirm. Here you can see there are few bowel loops going. So it is a case of traumatic rupture of diaphragm and herniation of the bowel loops. You have to do a CT. But here you can see there is collapse of the lung and a classical pneumothorax. You can do an ICD directly. Here, this is golden sign of right upper lobe collapse. Golden sign of right upper lobe collapse. So you have to do a CT and find the cause. So here, only in this case, you can go and directly put the ICD, because all other cases are because of some other pathology. Because so the examiner, so this was a little bit tricky, lengthy question. You should know all different types of X-rays. Then only you will be able to make a diagnosis. So you should know common lung pathologies. See, this is classical pleural effusion. Here you can see there is an S-shaped pattern with obliteration of costophrenic angle. Sorry, see, there is obliteration of costophrenic angle. S-shaped curve is there, so pleural effusion. And this is a case of hydropneumothorax. Hydropneumothorax. Okay, this is air, this is fluid. So hydropneumothorax, pleural effusion, pneumothorax, all these X-rays you should be very, very confident. You should never make any mistake in these commonly seen X-rays like pneumothorax, hydropneumothorax, and pleural effusion. Okay. Another thing is this is consolidation, which is seen in pneumonia. Okay, pneumonic consolidation. See, there is opacification here, but there is no mass effect. There is no tracheal pull. But what happens in collapse is, see, the major fissure has been pulled up. This is collapse. There is pulling of major fissure. The major fissure is pulled upwards. Okay, so these are the routinely seen X-rays. So you should be very thorough with these X-rays. Okay. Another important thing is foreign bodies. Okay, foreign bodies are also very important. This is a 30-year-old male with a retained fragment of glass in his finger. So which of the investigation you will do first? Okay, whether you do MRI first, CT first, Doppler or plain radiograph, always understand plain radiograph is excellent in picking up glass objects. See, here this is a glass object which is seen in a plain X-ray. So you can easily pick the objects with the help of plain radiographs. Also ultrasound of the local part is very useful for picking up these foreign bodies. Whenever you are dealing with intraocular foreign body, ultrasound of the eye is excellent investigation. So see, this is an ultrasound of the eye. You are able to see the foreign body here. So there is no radiation exposure, very easily able to just you can put a probe, you can see the foreign body. Okay. Also, CT is very excellent in demonstrating ocular foreign body. Never do MRI. Okay, because never do MRI because it may harm the patient. It because of the strong magnetic field, the object may come out. It can result in the globe rupture or expulsion of the intraocular components. Okay, so never do MRI. You can do an ultrasound or CT to look for an intraocular foreign body. I hope that is very clear. Other important thing you have to understand is the bone lesions. Okay, so we will see this is an epiphyseal lesion in unfused epiphysis. So when you are seeing an epiphyseal lesion in an unfused epiphysis, the thing you should come is chondroblastoma. So the chondroblastoma is also known as Codman's tumor. It will be having chicken wire type of calcification in HPE. All these are the points you should remember. So this is another classical image of what is this? You see here the epiphysis is fused. So this is a mature skeleton. So when you are seeing mature skeleton with involvement of the epiphyseal region, soap bubble appearance, all these are features of giant cell tumor. Okay, GCT. So that is the thing. The patient will be mature. He will be around 20 to 30 years of age, and there will be subarticular destruction of the bone like this. But this is the case of ABC, which you can easily confuse in the exam. But ABC is usually metaphyseal. Okay, it is usually metaphyseal. It is seen in skeletally immature. See, this is the metaphysis, this is epiphysis. The physis is not closed. So this is a skeletally immature patient. So ABC is seen in skeletally immature patient. So here, if you're seeing some stalk-like lesion like this, what is this? This is osteochondroma. They will be seen as pedunculated lesions going away from the epiphysis. So bone tumors, very, very important, multiple time asked, benign tumors as well as malignant tumors. This is the classical malignant tumor with the sunburst appearance of sunburst periosteal reaction, which is perpendicularly oriented like this, which is seen in osteosarcoma. Classical onion peel reaction seen in unfused epiphysis. So baby, so this is Ewing sarcoma and large sacrococcygeal lesion. So this is sacrococcygeal teratoma. And histologically, you will be seeing physalliferous cells in sacrococcygeal teratoma. So all these are the important points I'm rushing through because of the lack of time. But you should remember before you go to the exam, you should read about chondroblastoma, GCT, how to differentiate between GCT and ABC. Actually, the differentiation is very easy because GCT occurs after skeletal maturation and ABC occurs before skeletal maturation. So it is very easy. If you see the X-ray image carefully, you will easily able to differentiate. Usually, GCT is seen in the region of epiphysis, whereas ABC is seen in the region of metaphysis. See, it is seen in the region of metaphysis. It is longitudinally extensive like this. Then osteosarcoma, Ewing sarcoma, all these are very important. Now, hazards of radiation is another very important topic for. I think I will just finish in another 10 or 15 minutes. Okay, so please be patient. I will finish in 10 minutes. So the thing is, hazards of radiation is very, very important. So here you can see for a pelvis, external beam radiation is given for endometrial cancer. So which of the following organs is most radiosensitive? You know, rapidly dividing cells will be the most radiosensitive. We all know ovaries and testes are rapidly dividing organs, so they are most radiosensitive, whereas neurons in the brain are slow, they won't divide, so they are most radio resistant. They're very much radio resistant. Okay, so they are very much radio resistant. Ovary, bone marrow, all these are very much radio sensitive. Okay, so simple things. Other important, sometimes they will ask you which of the following cell cycle phase will be most radio resistant. We all know S phase is the most radio resistant, as well as G2M phase is the most radio sensitive phase. Okay, so just all these basic points you should never forget. Okay, because sometimes it will help you to